Sure, thank you, Clive. And yeah, today I hope to present kind of an overview of COVID-19 and the virus responsible for it, and hopefully leave some time for questions as well. I shamelessly stole a lot of slides, borrowed a lot of slides, I guess I should say, from set of presentations that were delivered just yesterday at CROI, which is the major HIV conference in the United States, that, by the way, was canceled as an in-person meeting and is now an entirely virtual meeting. So that's why I have to acknowledge the materials I'm going to present were mostly prepared by other individuals, but because it was such an excellent and timely update, I thought that was the best way to go. I have no relevant disclosures. Our learning objectives are to hopefully summarize knowledge to date regarding the epidemiology, clinical features, pathophysiology, and management of COVID-19, which is the illness associated with the SARS-CoV-2 virus pandemic. And I say pandemic because about 60 minutes ago, the WHO finally declared that, yes, this is a pandemic. And then discuss implications of these findings for the Caribbean region. So a little bit of nomenclature. Coronaviruses, we've been calling this the coronavirus, but there are actually a lot of coronaviruses out there, most of which just cause the common cold. So they've been around for quite a long time. They're called that coronavirus because under an electron microscope, they have what looks like a crown of the outer glycoproteins. But the ones we're most interested in are listed towards the bottom of the screen. These are these certain distinct coronaviruses that have cropped up in the last 2 decades that have been particularly dangerous to humans. There was a SARS, and then there was MERS, and the most recent one is what is being called SARS coronavirus 2 or SARS-CoV-2. Sometimes you see it as 2019 nCoV. These are the names of the viruses. Now, that is to be distinguished from the diseases that they cause. So the virus in question today, SARS-CoV-2, is what causes COVID-19, coronavirus disease 2019. And this this epidemic, or pandemic, I should say, of COVID-19 began in the city of Wuhan in China. It's been very closely linked to a seafood wholesale market, what it's known as these wet markets, where there are quite a few sort of live animals there. And the reason it probably started there is because the coronaviruses exist in their natural host in bats, and then can either pass directly to humans or via an intermediate species to humans. In this case, they suspect it might have been an exotic animal called pangolins that are sometimes sold at these markets. For SARS, the intermediate host was a civet cat. It was a camel for MERS. So basically, these are viruses that circulate, live in bats, periodically crop up in humans, really due to the close contact that we're increasingly seeing between humans and bats and other species. It spread very quickly within China. The first cases were sort of recognized on New Year's Eve, right about, and so probably first actually occurred in mid-December, and then spread very rapidly within the next 6 weeks within China, and subsequently to the rest of the globe. These are numbers that were just updated this morning. A total of over 120,000 cases worldwide, with over 4,000 deaths worldwide. This is a freely available website. It's one of the best ones I've seen to sort of graphically show what's going on. And as you can see, it's occurring on every continent with local transmission on every continent as well, which is why WHO is now calling it officially a pandemic. If you also look, it is there in the Caribbean region. I saw the first report of it being diagnosed in Jamaica just yesterday. It's been seen in Martinique. CARFA has a lot of information about it on its website as well. So unfortunately, the Caribbean region has not been spared, is not being spared, which is not that surprising given all the travel links between the Caribbean and the United States, the United Kingdom, and Europe. So basically the reason this virus has spread so fast and so far is that it is highly contagious. It's highly infectious. And numerically, we're still trying to pin down just how infectious it is. Immunologists use the term R0 or R0, the basic reproductive number. This refers to, okay, for every person who has a particular illness, how many people do they subsequently infect? And the higher the number that is, the more quickly an epidemic can spread due to the sort of exponential increase in the number of cases with each cycle of infection. So on the left, those are just sort of examples showing this. Still a bit of a range for trying to figure out the reproductive number for this virus. It's estimated to be somewhere between 1.5 and 4, which would make it more infectious than influenza, less than measles, but nevertheless highly contagious. And what's especially sort of concerning about the infectiousness of this virus is that it's very infectious right from the start. And in fact, there's evidence that it is infectious even before individuals become symptomatic. It's been documented that there can be viral shedding in people who are asymptomatic, which makes it all the more difficult to control spread, because by the time you isolate someone who's symptomatic, it may be too late. They may have had contact with others. Now, the vast majority of cases to date, of course, have been in China, and that's where it's been the longest. So it's worth focusing a little bit on what's been learned from this epidemic in China. And these are some of the key features that have come out of that, as summarized by a senior epidemiologist at the World Health Organization who very recently returned from a fact-finding trip to China. The majority of cases arise from close contacts of symptomatic cases. That's not surprising. In China, the transmission was primarily driven by family clusters. So, people spreading it within their family. And you get lots of people infected in that way. The secondary household attack rate, that refers to, if person A in a household has it, what is the probability of a person B in that same household contracting it? It was estimated to be 10% early on. In China, they were not seeing much transmission in closed settings like health facilities, nursing homes, or prisons. However, here in Washington State, we are clearly seeing that happening. There is a local nursing home that has 20 deaths so far from this, and was really clearly a site of a rapid spread of the virus. Transmission in schools was not observed in China. However, a couple caveats to that: they closed their schools very early, and also, as we'll see later, the diagnosis in children, school-age children, has been relatively low, although that's not to say that they are immune to this. All right, some features about natural history. At the time of diagnosis, roughly 80% of cases are mild or moderate severity, 15% are severe, and 5% are critical. About 10 to 15% of those mild moderate cases become severe. About 15 to 20% of the severe become critical. I would say roughly mild moderate means you're ill but don't require hospitalization. Severe, you require hospitalization. Critical roughly corresponds to needing ventilator assistance, some kind of assistance to breathe. Average time from exposure to symptom onset appears to be 5 to 6 days. From symptom onset to recovery from mild cases, 2 weeks. Severe cases can be up to 6 weeks. In those cases which are fatal, the time from symptom onset to death has been 2 to 8 weeks. In some patients, especially the elderly and those with underlying health condition, we've seen very rapid, alarmingly rapid progression. Truly asymptomatic infection, the rates of this are very hard to know because we're not doing serologic testing at this time. Molecular testing, however, suggests that this is rare. Now, you can pick up cases of this in patients who are not having symptoms, but they almost always then develop symptoms later on. Children clearly seem to have milder disease than adults, and we'll talk a little bit more about that. So this is kind of a schematic trying to sort of summarize some of what I just said. Again, 80% of cases at presentation, mild to moderate in severity. Vast majority of those will recover. Roughly 10 to 15% severe at presentation. Roughly 5% critical at presentation. Much higher proportions of those do progress to death. So this is, again, showing that in a different format, a bar chart. This comes from 44,000 patients, nearly 45,000 patients, again, from China CDC weekly report. All right, a few key points about the virology and shedding of this. As I mentioned, shedding tends to be highest very early in the course of disease. Interestingly, this is different from what we saw with SARS. And that is unfortunate because it'd be nice if we had a little bit of a lag time between symptom onset and the peak of viral shedding and infectivity to others. Clearly the shedding, and this is even more alarming, can occur even prior to symptom onset. Interestingly, the virus itself can be isolated from stool samples. However, we have not seen any evidence of fecal-oral transmission to date, so it's not clear that that's actually going to be an issue. The shedding usually continues for about 1 to 2 weeks in mild to moderate cases, but it can go on for over 2 weeks in severe cases. Patients who recover clinically, even after they're completely asymptomatic, can still be PCR positive. And so there have been a few case reports suggesting that individuals who recovered may have been reinfected with the same virus and got ill again. Not clear that they truly became reinfected. I think a lot of experts think that more likely they simply still had traces of this that could be detected by PCR, which is a very sensitive molecular detection technique. All right, so let's talk a little bit more about the clinical features of the illness. Typical signs and symptoms, and these data come from China, published in various journals. Fever, cough, fatigue, myalgia, arthralgia. These are the predominant symptoms that we're seeing in our patients, which again, yeah, looks a lot like influenza. So there's considerable overlap in terms of the symptom presentation with influenza. And of course, we are at peak flu season as well. So it's worth keeping that in mind. There are no particular set of signs or symptoms that can reliably discriminate this from other respiratory viral illnesses. It tends to be kind of a gradual onset in most. It can be a very acute onset in others, however. The cough is usually non-productive. Fever can be low grade. It's not typically severe. Interestingly, there are GI symptoms that frequently occur. Not in the majority of people, but we are seeing episodes of diarrhea, nausea, vomiting, and abdominal pain, and those can actually be the first symptoms. Incubation period estimated to be 4 to 6 days. As I mentioned before, that's the time from exposure to time of symptom onset. Most people will recover spontaneously and just need some supportive care. However, it can progress to a respiratory failure and multi-organ system failure. And the typical cause of death in COVID-19 is ARDS, acute respiratory distress syndrome, which is really a problem of a excess level of inflammation in the alveoli of the lungs. These air spaces that should be dedicated to simply exchanging oxygen and CO2 in the lungs to the blood vessels instead get filled with fluid, and they become little like water balloons. And so it's, as you can imagine, that interferes with oxygen transfer, and so it's hypoxemia that becomes the real problem for these individuals. There's actually little evidence of secondary bacterial infections in this situation. I know in influenza, we often see Staph aureus and bacterial pneumonia follow influenza. This is not really what we're seeing so far. It seems to be straight up ARDS, but ARDS, again, carries a pretty grim prognosis with a 30% mortality rate and many people requiring respiratory assistance. Even with recovery, people can be left with some pulmonary fibrosis. ARDS tends to be more of a problem in older individuals and interestingly in males, but we can and have seen this in younger individuals with COVID-19 as well. So the age distribution, based on these the data from China, show that it really affects the older population. If you'll notice, very few cases documented in those under 20 years of age. However, we know that the illness is milder in those who are under 20 years of age, and often those individuals will not actually seek care or get tested. So the finding that's shown here of very few cases in that age group may not be entirely correct. It may be that they are getting it as well, but because it's mild, they're not getting tested, and so we're not making the diagnosis. However, that does have significant implications for ongoing transmission, say within schools, for example. Now, everybody wants to know, well, what is the case fatality rate? Just how dangerous is this? And the case fatality rate depends very, very heavily on the age of the individual infected and the presence of underlying chronic health conditions. So the case fatality shown here in yellow is essentially what is the probability of dying, if you contract this illness. And as you can see, it's, as far as we can tell, very low, below 1% until you reach perhaps the mid-50s. It's individuals 60 or over where you really start to see a dramatic and exponential increase in the fatality rate that continues up into the older ages. And this is why this virus is so particularly dangerous for individuals who live in nursing homes, because they tend to be elderly and tend to have underlying health conditions. Overall, the case fatality rate, we're still trying to get a beat on it. It's estimated to be anywhere between 0.5 and 3.5%. However, the case fatality rate, again, is going to depend on, it's going to vary from individual to individual, and it's going to depend on really the setting, like, to what quantity and quality of healthcare is available to provide clinical support for those who become very ill. For example, if you have a very high level hospital with ventilators or even technologies like ECMO, the odds are much better than if you have none of that. So as I mentioned, comorbidity and advanced age, those are what really drive the increased risk for severe illness and death. A big question, especially relevant to this group, is what about those individuals who are immunocompromised? The short answer is we don't know. We don't have any data at present. We can kind of extrapolate from our experience with influenza and some other respiratory diseases and presume that this is likely to be worse for people with who are immunocompromised. So especially those with HIV at very low CD4 counts or not virologically suppressed. But again, we just don't really know at this point. So I think, anyone who's immunocompromised, whether it's due to medications, acquired or inherited immunodeficiency, should be very careful when thinking about this. Also, pregnancy. We only have observational data for women infected in the 3rd trimester at this point. Fortunately, we are not seeing any increase in morbidity, nor are we seeing any evidence of perinatal transmission of infection. And PCR testing of things like amniotic fluid, cord blood, infants whose mothers had this or were exposed to it, we're just not seeing it. So hopefully that will continue to bear out, but at least so far so good when it comes to the effect of this on pregnancy. So what do we suggest for our people with HIV? What we suggest is actually very similar to what we would suggest for anyone in the community. Anticipate, and we're going to get to this, that with increasing measures of social isolation and possible disruption of supply chains, it'd be good to ensure that you have an ample supply of medications, at least 30-day supply at all times if possible. Make sure vaccinations are up to date. The last thing you want to do is get this virus and also have influenza or streptococcal pneumonia. Establish a plan for clinical care for in case individuals with HIV need to be isolated or quarantined. I know here at Harborview, University of Washington, we're really relying a lot more on telemedicine, ideally a visual, but I've, for example, in my HIV clinic, have been substituting in-person visits with telephone calls because I think it's in my patient's best interest to not be traveling out in the community, not coming to Harborview, where we have had several cases of this already, and thereby avoid potentially being exposed. So I'm trying to do as much of my clinical care right now remotely rather than face-to-face with my HIV-infected clients, as well as with my older clients who do not have HIV and those with underlying health conditions. All right, so let's shift a little bit to talk about some public health measures. And one of the issues we've really been grappling with here in Seattle is personal protective equipment for healthcare workers. We're having to look very closely at our supplies of things like gowns, hoods, masks even, because we're anticipating a huge surge in the need for this kind of equipment. And I would advise your health facilities to be proactive about trying to get and stockpile these supplies as much as you can, so that you don't face a shortage if you are confronted with a massive surge in need. Testing kits. We really screwed up in the United States in this regard. We really botched the rollout of testing kits here in the United States. I'm not entirely sure why. That's a whole different topic. But suffice to say, testing was very much delayed, and that's created a lot of problems because I think we missed a real opportunity to fully understand the contours of the epidemic and get on top of it early on, because we did not have testing available in the quantity we needed. And we're trying to scale up even now. I feel like we're not there where we need to be. Contact tracing, this was aggressively performed in China, and it actually seemed to have had a big impact. Quarantine of people who have it definitely should be performed. Quarantine of contact should be considered. These can be very socially disruptive, but at the same time, they can potentially be very effective. Prepare for community mitigation efforts. This is things like reducing crowd size, limiting public events, keeping distance from one another, and public messaging about all this is going to be really important. So to dive into that a little bit more, the whole idea of trying to implement these measures is, well, ideally one would prevent the epidemic from occurring locally, period. Here in the United States, as well as in most of the, many parts of the world, we're sort of too late for that. The epidemic is here, and we're not going to be able to prevent it. In the Caribbean region, might be possible. I mean, it's only a few cases we've seen so far, and it's conceivable that with very aggressive action you could prevent an epidemic here. But it would require aggressive action, given how infectious the virus is and how it can spread even before people are symptomatic. But once the infection is established in a region or a community, the goals of community mitigation are to really try and delay the peak of the outbreak and make that peak less severe. We're trying to flatten the curve, so to speak. So on the left in purple, this is sort of what happens in a pandemic when there's no intervention. You get this very sudden and very large spike in the number of cases. This, for example, is what was seen early on in Wuhan in China. This is what is currently occurring in Italy. And not that they had no intervention, but nevertheless, the problem is that the epidemic is really outstripped the healthcare capacity locally. In China, they scaled up massively. They built hospitals within 2 weeks. It was pretty extraordinary what they did to sort of try and meet the need. But if you can mitigate the spread, at least slow it down, you can reduce that spike of the curve to a level where it doesn't exceed the capacity of your healthcare system to address it. And that is going to diminish the overall cases and the health impacts. In other words, you hope to not be in a situation where there just aren't enough beds or capacity of your healthcare system to treat the people who are sick. So these are a number of the interventions that can be used in community mitigation, and I present these various interventions in the context of another epidemiology term called the effective reproductive number, or RE. Essentially, if you can make a significant impact on all four, on some combination of these four variables, then you can reduce the effective reproductive level to less than 1, and that's when you break the epidemic. That's when it starts to peter out, because for every individual infected, there's less than one person who is subsequently infected, and the epidemic starts to burn out at that point. And encouragingly, that is what has been seen in China as well as in South Korea. So these variables are the number of contacts per day between individuals. You address that through measures like social distancing, self-quarantine, encouraging people to work from home, no social gatherings, et cetera. Just a few minutes ago here in Washington State, the governor announced that any public gathering of more than 250 individuals would be banned for the time being. Again, all in an effort to limit contacts between people who might be infected. Next variable, the probability of infection per contact with another individual. Well, within the hospital or clinic setting, that means wearing and properly disposing of personal protective equipment. In the public sense, that means things like cough hygiene. You cough into a handkerchief, a Kleenex, or into your elbow. You don't go out if you're sick. You keep yourself at home. You wash your hands very frequently. Next variable is the infectious period. You try to curtail this with timely identification and treatment of individuals who have it. That's where having sufficient and aggressive testing and contact tracing becomes very important. And then population susceptibility, the last variable, that refers to things like trying to vaccinate the public. That's not relevant at this point. Of course, we have no vaccine, and it's not likely we will have a vaccine for probably at least a year. So let's talk a little bit more social distancing. Many schools in Washington State and across the world have closed for this reason, just to limit the potential spread of germs between children. Here in Seattle, everybody's being encouraged to work from home as much as possible. Don't come into the office if you don't absolutely need to. Limit gatherings, as was mentioned. Stay at home if you can. These are just a few things I mentioned. The governor announcing limiting of gatherings. We have now a drive-through testing site for UW Medicine employees, so you don't even have to go into a clinic facility in order to get tested if you have symptoms of the COVID-19. And that other picture, Pike Place Market, very popular tourist space in Seattle. Very, very unusual to see it deserted like that. So people are really hunkering down locally. Washing hands, this is really enormously important. 20 seconds soap and water, that is the best way to do it. Use hand sanitizer if you don't have access to soap and water. Try not to touch your face. The way this virus is spread is through respiratory droplets, pretty much the same way influenza is spread. It's not so likely that you inhale this virus directly from the air. That seems not to be the case. This is not like tuberculosis or measles. Far more like influenza and other colds. It's respiratory droplets that either fall on surfaces that you then touch your face and get it that way, or if somebody is very close to you, coughs, those respiratory droplets could land directly on your face and get in through mucous membranes that way. So these are WHO guidelines basically echoing the same thing. People all over the world are wearing masks, and that is really not necessarily an appropriate thing to do. If you are sick, if you have any kind of respiratory symptoms, you should wear a mask in order to reduce your risk of spreading those droplets to others. However, wearing a mask out in public when you go about your daily business is not likely at all to help you and could easily backfire. Having that mask on, it's human nature to be constantly trying to adjust it and make it fit better, or it becomes uncomfortable. Then you touch the mask, you're touching your face. That's not good. Moreover, if it does get exposed by chance to droplets from somebody else, that mask is now contaminated. It would need to be disposed of very carefully and and properly immediately, or else it just becomes yet another fomite, another source of viral particles that is now right strapped to your face. Again, you're going to touch that mask, and you're very likely to then get it on yourself. And last but not least, we're running into supply issues with these masks because they're being bought up by the general public. And where they are really needed is by healthcare workers who are providing direct face-to-face contact with people and who cannot avoid being close to them in caring for them. Okay, healthcare facilities, quickly. The UW-Medicine has generated quite a few procedures and protocols. Of course, defer to whatever local guidelines are set up. However, I want to offer a possible head start on all of that to countries and facilities in the Caribbean region, because we've already gone through all this, and we've developed a lot of protocols and procedures that are freely and publicly available at that website. So if you go to that website, you'll find all these algorithms and policy statements that address how to manage everything from taking off and on personal protective equipment, how to do phone triage, how to screen patients when they check in, how to manage a healthcare worker who have potentially been exposed. All of these issues are there. Here's one example. When, for example, when do you use droplet precautions, which is what you use for influenza, versus when would you feel compelled to use what are called respiratory precautions, the kind of much more high-level precautions that we usually reserve for patients with tuberculosis, for example. That would only be for those who are critically ill, or if you're doing a procedure that might aerosolize the virus from their secretions. So just one example of the kind of resources you can find on that website. And I think it's worth taking a look to see if you might be able to quickly and simply adapt them to your own region. Now, these are just statements from the last day or two. Anthony Fauci is the head of the National Institute of Allergy and Infectious Disease at the NIH. He's probably the most trustworthy federal scientist in the United States on this regard. And these are a couple of his statements. We would like the country to realize that as a nation, we can't be doing the kinds of things we were doing a few months ago. It doesn't matter if you're in a state that has no cases or one case. It is critical because we must be much more serious as a country about what we might expect. A couple of cases today are going to be many, many cases tomorrow. And then another one, officials must pull the trigger on aggressive intervention. Time matters. 2 weeks of delay can mean the difference between success and failure, in alluding to our experience with the Spanish flu. The WHO is also, the Director General put out a statement just this morning saying he's very alarmed by the relative lack of action by many countries with regard to proactively taking steps to try and prevent and address this. And just one last word, beware of stigma. This started in Asia, and we're seeing a lot of very unfortunate stigmatization and discrimination of those of Asian descent. And stigma, as we very well know from HIV, is the enemy of public health. So I'll stop and summarize key points. It's a highly contagious novel coronavirus. The illness caused by this coronavirus, SARS-CoV-2, has a broad spectrum of severity, from largely asymptomatic to critical illness resulting in death, typically from ARDS. Overall case fatality rate estimated to be between 0.5 and 3.5, but is unevenly spread among population. Again, individuals over age 60 and those with chronic underlying health conditions are at highest risk. Early and aggressive epidemic containment and mitigation strategies are critical and necessary to prevent the impact of this virus on your communities. So I'll open it up for questions and comments.